Thank you. Thank you, Mr. Chairman. Again, repetition, perhaps eventually someone might hear what's being said, so there'll be a few things you'll hopefully hear that will be consistent messages. We know two-stage revision is gold standard for the management of periprosthetic sepsis. The interval management of soft tissues can be assisted by the use of local antibiotic delivery systems. However, controversy and uncertainty continue to exist both between the issues of whether we use static or mobile spaces, the choice of antibiotic and the dosage. The uncertainty exists because the literature is poorly controlled, it's heterogeneous, it's based on people's opinion, their experience. There's very little in the way of randomised controlled trials, and the outcome measures are variable, and the definition of a cure of sepsis is not always clear. The other thing that complicates matters further is that there's been a significant bias towards the use of mobile spaces in the last 15 years, and so the use of static spaces is really limited in the literature. I'm hopefully going to make it a little simpler for you to understand and where you might use a mobile versus a static spacer and how you might load those with antibiotics. So why have one? We know consistently for all spaces they deliver high concentrations of antibiotics to the periprosthetic tissue, they maintain soft tissue tension and they reduce dead space. They're all good things. The addition of a mobile spacer hopefully maintains a functional range of motion for the hip or the knee and potentially makes the second stage of the procedure easier. So hip spacers can be handmade with an endoskeleton. I think you need to use an endoskeleton for strength. You can add your own antibiotic. They're less expensive than the manufactured versions. However, they do have issues with subsidence and dislocation and add significantly to operative time. You can use a commercially available customised spacer. It gives you much better leg length and offset control. You get sizing options on both the femur and acetabulum and enables you to use, again, high dosages of the appropriate antibiotic, but of course there's a cost. The hybrid version, similar to the knee discussion, can be used where we autoclave a cheap or the previous implant, use a pore cement technique, use a thin polycup is also quite useful. Similarly, knee spacers have gone through a similar process, starting with a static hamburger style. Problem with this is really the instability and bone erosion that arises. The benefits, therefore, of using an endoskeleton are evident. Handmade dynamic spacers became fashionable a few years ago. They supposedly give a congruent articulation. They're less expensive than the manufactured variety. You get to, again, prescribe your dosage of antibiotic. The problem is crepitus due to abrasion. It's quite time-consuming, and there's a serious question mark over the interim function in any case. So the use of commercially available moulds is something we do occasionally use. Again, abrasion is quite significant with these patients, and they complain of irritation, and so the third option, which I do prefer, is to use a hybrid dynamic spacer, very much in the way that Arun and Ridian have just spoken. You get a smoother articulation. You can use a re-sterilised or a new femoral component, and you use a polyethylene with a thick cement mantle, again with pore cement technique. And it's a relatively straightforward procedure. It's not time-consuming, and you still get good doses of antibiotic to the local space. Usual complications occur, and this occurs with any spacer: bone loss, fracture, dislocations. They're all associated with difficult cases. These are not happy patients. What are the outcomes? We know that mobile spacers generally, in comparison to static spacers, have similar infection rates, but the mobile spacers have slightly better interim results. I won't dwell too much on that for time reasons. So when would we use a static versus a dynamic spacer? So generally speaking, I'd prefer to use a dynamic spacer if possible. That is when there's good bone support, a good soft tissue envelope, good soft tissue stability, so you don't need flaps, you don't need to immobilise the patient for other reasons. And my preference is a hybrid autoclave femoral component with lots of cement. A static spacer, on the other hand, if used, should be reinforced with an endoskeleton for stability. So antibiotic choice and dosage, of course, they should be thermally stable, broad spectrum. They should elute from the cement with low influence on the mechanical properties of the cement and have a history of low or no risk of allergy. And that generally comes down to gentamicin, vancomycin, tobramycin, clindamycin are the broad-spectrum antibiotics that we will likely use. If you're thinking about using antibiotics in a single-stage procedure, or you are really, it's really helpful to have a pre-operative identity of your organism. I think that's quite well established, and certainly the benefit of doing a two-stage procedure is it enables you to get good samples of your local environment at the time. And again, the same emphasis to consult with your microbiology colleagues, and we sometimes struggle to have such excellent engagement as some of Ridian's colleagues, I would have to say. Two antibiotics are better than one. There are very well declared benefits of synergism when using those in your spaces. Gentamicin, clindamycin, if there's no broad spectrum resistance, but for the MRSA, MRIC patients, gentamicin and vancomycin are good choices. Use up to 4 grams of cement per mix. It requires additional antibiotics to most of the commercially available preparations, remembering that over 4 grams per 40-gram mix significantly alters the physical characteristics of your cement. Interval duration is poorly defined. It's thought to be a minimum of 6 weeks, but that's very much historic and empirical rather than scientific evidence. Very little risk of systemic toxicity, but that doesn't mean we shouldn't monitor our patients with regular renal, hepatic and monitoring of their skin for allergic reaction. I won't run through case examples in the interest of time. And just a final recipe for success, the same themes. It's a thorough debridement. You can't do anything without the thorough debridement. Identify the organism or organisms at every opportunity. Use high-dose combination antibiotics. Implant a strong and stable spacer. And if bone and soft tissue environment allow, use an articulating spacer. Thank you for your attention.